right, everybody, I think we'll get started. So once again, welcome everyone to the first Novo Nordisk Network for Healthy Populations seminar for 2024. Happy New Year, everybody. My name is Lorraine Lipscomb. As you know, I'm the network director, and I'd like to start before we begin the seminar, with a land acknowledgement. And I'll start by acknowledging that I'm coming to you from Toronto, which is covered by Treaty 13. But we would like to acknowledge that the land on which the region of Peel operates, which is where our center is hosted, is part of the treaty lands of the territory of the Mississaugas of the Credit. For thousands of years, Indigenous peoples inhabited and cared for this land, and in particular, we acknowledge the territory of the Anishinaabe, the Huron-Wendat, the Haudenosaunee, and the Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. And we're grateful to have the opportunity to work on this land, and by doing so, give our respect to its first inhabitants. And we are all treaty people, and many of us have come here as settlers, immigrants, newcomers in this generation or generations past. So we'd also like to acknowledge those of us who came here forcibly, particularly as a result of the transatlantic slave trade, and pay tribute to the ancestors of African origin and descent. So thank you and welcome everyone to the seminar entitled "Small Steps for Big Changes: Lessons Learned on Implementing an Evidence-Based Diabetes Prevention Program in Diverse Urban Communities," presented by Dr. Mary Young. And I'm just so thrilled that Mary, who's coming to us from British Columbia, has agreed to present to us today. And before I introduce her more formally, I'd like to quickly review some housekeeping items. First of all, we appreciate our audience muting themselves during today's presentation. There will be an opportunity for questions at the end of the session, and we'll be inviting questions both through the chat box or by using the raise hand function. If you have questions during the event that you'd like Mary to address at the end of the session, please put them in the chat box. I will keep a record of them. Lastly, please note that today's session is being recorded, and we will make the recording available on our network's website. Now I'd like to introduce Dr. Mary Young. Dr. Young is an associate professor in the School of Health and Exercise Sciences at the University of British Columbia Okanagan campus. A major research interest of hers is developing evidence-based diabetes prevention interventions designed for community implementation and sustainability, with a lens towards improving equity, diversity, and inclusivity in all research endeavors. Dr. Young was named a CIHR Early Career Foundation awardee, Michael Smith Foundation for Health Research Scholar in 2015, as well as the Killam Accelerator Research Fellow in 2023. Dr. Young leads the Diabetes Prevention Research Group and is the founder of the diabetes prevention program called Small Steps for Big Changes. She's also the director of UBC's Center for Health Behavior Change. And most recently, Dr. Young received a CIHR grant for which she's the nominated principal investigator. And this is a CIHR Healthy Cities Implementation Science Team grant, which is titled "Small Steps for Big Changes: Implementing an evidence-based diabetes prevention program into diverse urban communities." And so we are really excited that she's going to be talking about this research, which will test the implementation, effectiveness, and sustainability of a diabetes prevention program in urban communities across Canada, as well as Australia. So without further ado, I'd like to pass the mic on to Dr. Young. Thank you, Dr. Young.
Thank you very much, Dr. Lipscomb, and to everyone at the U of T Novo Nordisk NHP. I'm really appreciative of the opportunity to talk and share my passion today. I'm also really excited for the audience members, so thank you very much for your attendance. So I appreciate the land acknowledgement that Dr. Lipscomb has already done. I'm residing from the area where I stand today, which is the UBC Okanagan campus, which is situated on the unceded and unsurrendered territory of the Seal Nation, home of the Sukanagan. And so I just want to acknowledge also the land in which I work on, and I'm standing in today. I also want to acknowledge all other areas who, for Zoom attendees who are not within the Huron-Wendat, Seneca, and Mississaugas of the credit area. So I have three aims for today, and I'm confident we can achieve that in the time permitted. I really want to start off by talking right away about practical strategies we can do in enhancing accessibility and as well as inclusivity when we're supporting or providing or creating diabetes prevention programs. I also hope to use our diabetes prevention program, Small Steps for Big Changes, as a bit of an example of how we've implemented the program in various communities. And I think this scale up approach takes away some of the ambiguity in the literature with respect to implementation scale up. So I hope to do that kind of step by step. And then the ultimate goal, it's lofty, but I do aim always to inspire and to motivate researchers, community partners, decision makers, et cetera, to come together and partner, because I really do believe that our future is critical for such partnerships to be rich and fruitful and mutually beneficial. So we can inspire more of those community-based partnerships. I think we're doing a good job. So that's the three aims, and I'll just begin with some warm-up stats that I know everyone in the room is aware of, and it's still critical to cover these points because it drives the passion that I have, and also a stark and strong reminder about likely why everyone is in this room and so interested in the topic of chronic disease and disease management and prevention. So we know we have a significant number of Canadians living with prediabetes, particularly concerning because, of course, up to 80% of these individuals don't even know they had it. So we're working with a population who we're trying to seek help. We're trying to reach literally millions, and yet many are not aware. And we also know that those millions of individuals, up to 70%, will progress to type 2 diabetes if left untreated. So we have this, I would say, quite a massive problem within Canada. And of course, these stats expand across the world. And yet we have had solutions for over 20 years now. We know from the major landmark trials in China, in Finland, in the United States, and others that diet and exercise modification programs can reduce this risk significantly. We know it's about 56% of those who engage in such programs are unlikely to develop type 2 diabetes. And yet, we still have a challenge. So even though we know those really impressive numbers, and we know that it works for thousands of people, we have this research practice gap. And that's because those critical landmark trials were conducted in clinical settings. And this is important for efficacy and demonstration of effects, but it really demonstrates our focus on program design to assess efficacy is not the same that it will be in community. There's time restrictions, there's cost restrictions, and there's organizational restrictions that prevent the uptake of such landmark trial intervention pieces into the real world, which is, of course, where we can make it accessible for everyone. So we need to implement in an accessible manner what we know is effective based on some of these large clinical-based trials. And so what, as I mentioned, I'd love to do today is just talk through some of the steps we've taken to develop an evidence-based intervention and bring that to the community. So I'm just going to start right at the rung one, phase one development, because this is really what I believe is quite critical. Phase one was the development, and we began that in the middle section of the knowledge to action framework. So we knew at the bottom that the problem existed. We know the millions of people, we know what works, but we had to move upward before we could go downward. So we needed to synthesize the evidence in terms of community-based interventions, in terms of readiness of organizations, in terms of developing our tools. And so we almost started at step one, moved backwards to knowledge inquiry, and then pulled down in the phase one, or the action cycle of the K to A. And what we came up with was small steps for big changes. We developed this program knowing and deciphering the critical behavior change techniques that are required for sustaining behavior change, but we also did this in collaboration with both individuals living with prediabetes, individuals living with type 2 diabetes, and our healthcare provider colleagues. Everything from the name of the program to the colors of the program has actually been influenced by our partners. So Small Steps for Big Changes is a counseling program, and it helps people at high risk of type 2 diabetes make lasting diet and exercise changes. So we know that our techniques employed within this program needed to be both personalized, but it needed to be brief to reduce the barriers that other programs have had, such as cost. So briefly, Small Steps for Big Changes provides one-on-one counseling sessions only 6 times. From there, we do follow-up sessions, 1 to 2 of those, to track progress, to create and revise goals, but also from a research perspective to assess. So we collect some data at those times. So each session is guided by motivational interviewing, counseling techniques, and we do, in those 6 sessions, provide 20 minutes maximum of supervised exercise. And this is an in and out manner, not a stand by somebody and interact with them, but rather checking in to see if they're progressing in their heart rate goals. So as you can see on this slide, our motivational interviewing counseling style is very focused on autonomy, client-centered care. We focus on listening to the client rather than prescribing. And in those 6 sessions, we're covering briefly what I've listed here: self-monitoring, goal setting, relapse prevention. We focus on education, as well as education, particularly on the sustainment rather than the change of behavior goals. And we do provide that supervised exercise, and then we always start our sessions with a reflection of how the behavior changes are going. And so throughout our training, as I'll talk a little bit more later, we really train individuals to deliver the program focused on conversing and listening. So after we developed the program, we were ready to test it in pilot phases. We did this with 32 participants in the lab here. And we focused first on assessing whether there was adherence, short-term adherence, 1 month free living, as well as weight loss and fitness improvements. We found that, so once we progressed to another pilot assessing whether the risk factors for type 2 diabetes were reduced and maintained for up to 6 months post the program completion. It was, so we conducted a full-blown RCT, again in the lab with 100 participants. We first focused on extending the evaluation. So does the benefits that participants derive be maintained for up to 12 months post intervention? So it was. So we continue to focus on looking at the core components of the Small Steps for Big Changes programs to really critique our own selves. Is this actually changing the way we anticipated it changing? Why are we getting these good results? What can we rely on seeing in the future? So we know behavior change, in particular sustainment of exercise behavior, is focused on self-regulatory efficacy. So our confidence in our abilities to engage in these behaviors despite the barriers that come up. And once we demonstrated that this was in fact what was mediating exercise behavior, we then transitioned into looking at, sorry, my pictures are in the way, here we go, what we can do from a low-cost perspective. So we began embedding text messages to participants and assessed their efficacy at self-reported exercise for the 12-month follow-up period. We found that was successful. So we moved on to looking at what types of acute responses were occurring during those 6 sessions. So while we were engaging with participants, what was happening to them from a psychological perspective, and what that positive was. So then we went backwards. So we audited our own audio recordings, and we assessed all our program intervention content and assessed whether we were delivering the behavior change techniques that we intended to. And indeed, we were. So we know we have these tightly controlled trials, just like I was running in the lab. As an RCT, we do this to test under ideal conditions, to have confidence with the results we're getting. Now it was time for us to move into effectiveness and implementation, which have higher external validity. So this is really where implementation science takes off. It's when we're using real world staff, real world settings, and seeing whether the program can still be successful at eliciting behavior changes. So we first moved to a hybrid effectiveness trial design. So we were asked at this point by Urban YMCA to bring small steps for big changes into their Y. We gladly accepted the challenge, and we delivered small steps for big changes as a research team, but in their facilities. So we demonstrated that we are reaching a wider audience and that we still had that 6-month effectiveness results, which was fantastic. We also demonstrated that our collaborative process with the YMCA was very strong and deemed lucrative and beneficial for them. And that was really important for us to demonstrate. So from there, we expanded to 2 other urban YMCAs, and this was a critical difference. This is where I had always dreamed of wanting to get to, is taking away the researchers from the delivery aspect. This is not only cost effective, but it's important from an organizational success and buy-in perspective. So we trained the YMCA staff to deliver small steps for big changes in this effectiveness urban pilot trial. We confirmed that both the clients running through the program and the YMCA staff, who are now our trainers, were highly satisfied with the program delivery and receptivity. We then demonstrated that there is very high fidelity of the delivery by YMCA staff. So this means they were delivering the content as intended, as we delivered it. There was no difference between how they delivered it and how our research team was delivering it. And then finally, we demonstrated that those trainers who we had trained maintained their high delivery of small steps for big changes for up to 6 months. So we have 3 YMCAs in the Okanagan region, and from the first 500 people that have gone through our program, we track their HbA1c through a partnership with blood requisition laboratories. And we've demonstrated that 85% of the people that come into our program no longer have prediabetes 1 year post the program, using the ADA criteria and the WHO criteria of less than 5.7%. So we're very proud of these results, especially in comparison to the clinical trials in the past. So this is great. We're seeing effects when delivered by cost-effective YMCA staff. But we also recognize there's a lot of limitations in how we were running it. We were delivering the coach training in person over 2 days, and we recognize that this is not only cost inhibitive, but really difficult for scheduling for an organization which is very used to part-time staff. So we modified this into an online training that could be asynchronous. So we moved from demonstrating that the in-person worked and maintained those skills for up to 6 months, to then evaluating our online training platform, which demonstrated that yes, indeed, those YMCA staff members who take the online training are just as effective at increasing their knowledge and their self-efficacy to deliver that small steps in their facilities. So then we needed to consider and be, again, critical of our own steps. We were developing this process and we were successful at reaching individuals, but are we reaching those who we are designed to reach to help out most? So we embarked on a long-term goal of increasing in all steps of small steps for big changes, the equity, diversity, and inclusion. So we really went from back to square one in the development phase and critiqued all materials, all our delivery processes, all our partnership programs, all our meetings to better understand whether we were doing as we intended. And I think probably in my career thus far, this has been the most rewarding. First, we put our critique out there to the public to really share with the world, hey, this is where we're not doing well, this is where we are, this is what we would recommend for other individuals developing diabetes prevention programs to do. And I really think we put in a nice list of suggestions that it's aimed entirely to be helpful to others. We developed a module specifically on teaching our coaches how to be culturally sensitive and inclusive. And we've tested this module in its efficacy, as well as, so I won't share those results today just for time, but I do want to share that the individuals who have taken this training have been very, very receptive. Sorry, my clicker has gone away here. So just the feedback from our coaches who are in the real world at YMCAs delivering this, telling us that the reach really extends beyond just delivering our program, but it's advanced their skills that they can use in their organization. I'll go through a few of the pieces about advancing program equity. And like I said, we really wanted to expand our reach to those who need it most. So rather than focusing only on those convenient samples, we strive to reach remote and rural communities, particularly because there is no diabetes prevention programs or very often quite limited access to healthcare providers. So how can we reach those? We moved from all our recruitment and program materials. We're now working with immigrant populations, as well as in those communities with food insecurity challenges and food insecurity food banks, which I'm really proud of the partnerships we've developed there, as well as adapting all session content. And so briefly, some of the remote and rural communities we've gotten to work in since we've change everything to be online so that we can deliver training to coaches far and wide. Some of these are listed here, but it goes deeper than just rather spreading, but situating and changing the content so it is relevant for those who are going to take it. So one thing we heard when we moved to remote and rural communities is we don't have the staff. Yes, you can train our YMCA staff, but our parks and recreation facility staff, but we really need help because the manager is also the one delivering the content, is also running the front desk, and is also doing all these pieces. So we reduce the member services staff burden by changing our onboarding process to a process that works best for them. We also really listen to the communities we work and serve. So when they when they tell us things are too wordy or we don't like QR codes or we make those changes immediately. And this is just one example you can see on your screen to make it less overwhelming for those for a community that said it was too overwhelming. We've also learned to be really flexible in how we deliver our exercise protocol. So for us, we have a component of training that we know works and is efficacious. We try and stick within these particular heart rate zones, but we've worked with the community or multiple communities now that do not have a fitness facility whatsoever, but they have a public pool. So one example of us really listening and adapting is changing our entire exercise protocol to be able to be done in that local pool. We also always listen to what the clients say, to what our staff say is relevant to their communities. So we modify our workbooks and our program content for each and every community that we serve. In one location, we actually had to divide our delivery of small steps for big changes into two physically different buildings just because of the way that community ran. And we were able to do this in a smooth fashion so that no participants were lost and everyone received the same sessions. So I think these are just some of the examples of how not just we're trying to focus on increasing our access and making it more inclusive, but also how we really do listen to our partners and work with them. When we assessed our effectiveness, we were ready to test out running really far away. So we were contacted by YMCA Portugal and we're fortunate enough to begin expansion there. And this is just another small example of adaptation. Of course, we needed to modify all our language, all the materials. What we also learned is our cultural adaptation to motivational interviewing. And that was a really neat process, again, being really critical of ourselves and what we were assuming and not assuming. So that's been a really fun process in Portugal. So I want to share what's probably more interesting rather than from my perspective as a researcher, but from the perspective of somebody who actually has used the program and continues to work with us today. So this is a picture of Lois, and Lois has shared her story with us today and has given me permission to share that. So basically, in 2016, Lois was told by her nurse practitioner that she was pre-diabetic. And so she was sent information about small steps for big changes. And I'll just read from a brief storyline of Lois. So in October of 2017, I skeptically tiptoed onto the paths of small steps for big changes. Reluctantly at first, I attended the counseling and workout sessions at the downtown YMCA. The workout was the easy part. The counseling worked at getting to real life situations, triggers, and above all, reality. The more I learned, the more comfortable I became in this new space. I found that I looked forward to these sessions. I was learning from our young graduates and Small Steps for Big Changes staff at the YMCA. It inspired me to do my best with a great sense of humor and a unique perspective on life. Fast forward to late spring 2018. I am a graduate of the program. I'm almost at my goal weight, and I'm in the neighborhood of 160 pounds. During the program, I learned to make healthy choices by being knowledgeable about what I ate. Imagine being 59 years old and not really understanding what you are putting into your mouth. Further knowledge came later when Mary and her team maneuvered the program around our needs as clients. She provided us with cooking shows, monthly evening get-togethers with relevant guest speakers, and even a potluck dinner showcasing our new set of cooking skills that reflected my healthy choices. I think when you see just how hard the team works and it's just for you, you get even more excited by the program. Today, I run a weekly walking and hiking group of 7, and some of us are retired, so we get to gain at least 2 more hikes during the week as well. The group consists of all graduates of the Small Steps for Big Changes program. Mary and her team, I thank you for impacting my life in a profound way, for giving me opportunities to tell others about the program, and especially allowing me the chance to address this group. So that was from a few years back. I recently received a kind message from Lois sharing me that she actually is still participating in running her voluntary hiking group and that she's maintained her weight loss goal of 50 pounds for over 5 years. So the next stage that we're advancing into now is that final bit here. It's extending our Small Steps for Big Changes, as Lorraine mentioned, across Canada, as well as into the state of Queensland and Australia. And this is generously supported by the research agencies listed here. So the first piece we're going to do is expand into the 11 initial urban sites that are highlighted on the graph here, and then expanding into 30 more expansion sites for a total of 44 YMCA Small Steps for Big Changes delivery sites in Canada, and in Australia, 5 sites across the state of Queensland through our partnerships with the University of Queensland and Logan Healthy Living. So briefly, the summary of pre-implementation steps and implementation steps I have highlighted in 2 quick slides for those who are interested. So in the pre-implementation stage, the focus on hiring and training regional research coordinators to liaise with us, as well as our delivery team, has been critical. As you know, making something accessible and usable to the community that you are delivering and working with means that you need to hire and train local staff who really know the ins and outs of the program. We've identified site leads at each of the YMCAs that can oversee our coaches delivering the program at their respective sites. And we've formed committees as well as an overarching steering committee. So I believe this is critical in all implementation scale-up processes to have an oversight committee as well as research committees within the program. So our research committees in the program consist of sex, gender, and inclusivity committee, integrated knowledge translation program evaluation, and patient engagement committees. So moving into the next step of patient engagement, this is where regional research coordinators are meeting with our patient knowledge users to start adaptations of the materials and the content. And this is done so that we ensure the fit of the content for each site or each urban community. So while we have core components of Small Steps for Big Changes, we have these adaptation meetings to really see what is going to be critical, what does need to change in Small Steps for Big Changes to make it usable and accessible for each community. We've developed a website to create a community of practice for all coaches interested in being part of Small Steps for Big Changes. And this is how they can support and enhance education amongst each other. And finally, through collaboration, we have a municipal advisory committee, and this is where we develop recruitment strategies and referral pathways within each community. And finally, we also, of course, are training our YMCA staff to become Small Steps for Big Changes coaches. So once we've done all of that work, which we are just in the process of in 2024, then we begin implementation. And so in this implementation phase, we have made it a priority to host knowledge sharing meetings between our sites and our team members. And this is where we discuss the barriers and facilitators to delivering it. We assess organizational readiness. We work on what needs to be done, taught, provided, and what skills we need to develop within both our research team as well as our community partners to ensure a successful and, again, mutually beneficial partnership in these communities. Of course, the community of practice will be running in 2024 with all of our coaches across Australia as well as Canada, so they can learn from each other and continue to access this in our when they're delivering Small Steps for Big Changes. The follow-up with our patient participants is not just about data collection, but at this point is also about their iterative suggestions and changes to the Small Steps for Big Changes to make sure that we're always making it what they need. So final perspective I just want to share with you is one CEO of YMCA BC, Amanda Alexander, who also is the Chief Health Equity Officer. And so when I approached her, I told her about the program, asked if she might be interested. She was quite enthusiastic and shared these 2 slides with me to say, we want to partner because as the YMCA, this is our values, this is what we strive to do. And Small Steps for Big Changes supports this and helps us do this. So talking about an organization which is not for profit that aims for inclusivity and a welcoming environment for all people. So such a great fit allows us to reach participants, and John's story comes from willingness to share with the broader audience. John lives in Prince George, and where we are delivering small steps for big changes, and really talks about his challenges with finding a suitable program that is ready to meet him where he's ready to be met at. And when I heard this quote, I couldn't believe it, because one of our quotations when we're talking and going through our coach training is just that: we meet the client where they're ready to be met at. So it's been a beautiful fit so far. And our final stage of implementation scale up is to focus on sustainability. And we hope this phase never ends. Through our partnerships with YMCA, the goal is to be a program that can be implemented in the community that is beneficial to the YMCA and its users they serve and its missions they strive to seek for, as well as our goal as researchers to expand an evidence-based program to be able to assist community members, particularly those in Canada who are at risk of type 2 diabetes. So I think with that, I'll end on some big and very, very important thank yous. I run a center, but my lab, the Diabetes Prevention Research Group, is filled with very genius students, and that's really where the great ideas come from. And particularly the Small Steps for Big Changes program could not be what it is today without the participants who we've had the opportunity and the privilege to work with. They continue to help us adapt the program. Our YMCA partners make this implementation scale up possible, and we're very grateful for our funding sources that make this work fun. So with that, I'll end with questions, and perhaps I'll stop sharing my screen.
Thank you very much, Mary. And that was a really amazing presentation, and what a great journey. It's so nice to see the evolution of this program and this project all the way up to implementation, sustainability. And it's just congratulations for all the work that you've done, and also for your ability to now potentially expand it, not just for the whole of Canada, but even in Australia. So it's wonderful. Congratulations. And by the way, I just want to apologize. I mispronounced Mary's last name. It's actually Jung. It's not Young. So please accept my apologies. So Dr. Jung, we'll open it up for questions. So we have one from Krista in the chat. So do you have any suggestions for ways to involve diverse communities in programs like this? So do you need to have multiple programs or adaptations?
Yes, thank you for the question, Krista. That's a great question, and that's something we're really actively involved with. So I don't know if it needs to be always, but I think the ideal goal would be that diverse communities are involved in those adaptation, implementation meetings and planning workshops. Why I say that it might not need to be is sometimes the barriers that exist may be similar amongst two or more diverse community settings. It's been our experience that bring more people to the table provides greater fruitful discussion and brainstorm ideas. And sometimes when we pull back into the core components and the overall summary of what needs to change, sometimes those are similar amongst diverse perspectives. And so for my experience, when we've invited those who have decision-making powers at diverse community settings, we've always had the privilege of seeking one expert, and that's when I speak about municipality advisory committee members, those are those types of people. So I think it's ideal, but perhaps I wouldn't want it to limit somebody from reaching out, let's say, to a broad city that has multiple diverse perspectives.
Yeah, no, that's great. Thanks for that. Does anyone else have any questions for Mary? So while people are thinking about potential questions, I mean, I had a couple of questions. So it's great. I love that obviously you're focusing highly on physical activity. I think, a lot of research has shown not only in general is physical activity highly central to diabetes prevention and healthy living, but I've seen work, and I'm sure you have too, where when you're thinking about the two major behavior changes that for diabetes prevention, diet and physical activity, that physical activity is associated with greater adherence, just than diet changes. So with that in mind, it sounds like you're using motivational interviewing to help people develop their own goals around diet change. Is there anything more formal that's being provided with respect to diet counseling?
Yeah. Yes. Thanks for giving me the opportunity to clarify. So we stay within the realm of what is provided by Public Health Agency of Canada, which is primarily looking at Canada's food guide recommendations, most recent. And because our staff are YMCA trained individuals, that don't have registered dietetic practice. We need to make sure that we're not providing any type of formal advice, but we do inform and educate on the effects of increased and added sugar and refined sugar on blood glucose levels and management. So again, similar to what's provided within public health messaging, but we do shed light or share to highlight that, as well as focus on increased vegetable consumption and reduction of refined carbohydrates.
No,
So
thank
our
you.
three main pieces, refined
Right.
carbohydrates, added sugar.
And I guess then how will that be measured? Just like fruit and vegetable
Mm-hmm.
consumption? Yeah.
Mm-hmm. Yeah, we have two ways of measuring it. We have food frequency questionnaires, which we've used for quite a few years now, as well as we're using a photo image app in
Oh.
which we can assess more fine-tuned. Yeah.
Yeah, no, that's great. That's great. Thanks. There's another question in the chat. I'll just read it out from Laura Chiavarelli, sorry. Again, I'm not doing great with names today. Fantastic to see the progress and scalability of the SSBC program. Are there any plans for incorporation within the healthcare system, insurance companies, et cetera, to help with further spread of awareness and use, like referrals from the healthcare system, for example?
Mm-hmm. Yeah, that's the ultimate goal, isn't it? And we were speaking earlier, Dr. Lipscomb and I, about what could that look like, and where's the feasibility and such engagement with the healthcare system fully. And I think that's what our end of term of this decade will be, is trying to demonstrate and present that such materials to not just healthcare, but of course to the government, and demonstrate our cost savings. So a big part of the analysis for us is healthcare utilization cost analysis, in which we will hopefully be able to share in our reports the effectiveness of delivering this program on cost savings to the healthcare system.
Yeah, no, that's great. And I think, yeah, it's always a challenge, right, with the strapped healthcare dollars. Oh, yeah. Anyway, thank you for that. I see we have a number of questions. So Beju, Shaw, and then Jillian.
Hi, Mary. Nice to see you. So my question is more about your process, because when I listen to your presentation, and we spoke about this, when I listen to all the work that you've done, it feels like you should be ready to retire because you've done that much work already. So my question is, like, how have you managed to accomplish this huge volume of work in, not an entire career's worth of time? And what are your tips for the rest of us on how to be that productive and efficient and effective
You're
at
very
getting this kind of work
kind.
done?
Very kind. I'm standing far away, so you don't see how old I am. I really do mean it when I highlight and thank my students first. I'm fortunate to have a large team of students, and so a lot of the, you know, perhaps the bulk, the scope and this amount of work that I've been privileged to be able to be a part of is because of that large team. And then I think the other thing, and I really do mean it genuinely, the YMCAs each run separately and distinct from YMCA Canada. They really have permitted so much opportunity to reach a large number of people, which of course allows us to really analyze critically, like what is working, what is not, and kind of decipher in and out those pieces in a time efficient manner. So that's my secrets.
Yes, right place, right time, finding the right people and having a great team. But I'm sure you're an inspiration to them, Mary. I'm sure they it's not just that they're great, but you help them be great. Jillian.
Yeah, I echo Beiji's comments. Great work, Mary, and always impressive. I just wondered, and I missed little bit of the beginning, but thinking about the more recent expansion. So what do you think will be the biggest barriers to implementing this type of program in a very complex urban populations? And I'm thinking about maybe the generalizability or reaching those high need diverse communities such as lower income racialized populations, or people living in suburban areas such as Mississauga or Brampton, where just geographic access to getting to the YMCA might be problematic. And I know you're doing all that kind of data collection now, so this might be more what you think as opposed to what you've seen so far.
Exactly. Yeah, I appreciate that question. Thanks, Jillian. So one of the biggest challenges I think, or I anticipate, is our inability to translate it into all languages that are part of Canada. And so we are going to try and do our best. And certainly that's part of the adaptation pieces, but it's not as simple as it was in Portugal, where there's two primary languages, and we could stick with that and feel comfortable with that, and it seems to be working. So I think a basic one is challenges with language, our challenges with language. And then another piece that I anticipate being a barrier, and hopefully it's surmountable, but it is our referral processes. So really respecting that each and every province, and certainly different regions, the health authorities work very, very different, or is my crude experience. And so while we have blueprints that have worked very well, we anticipate engaging with health authorities in which that blueprint doesn't work, and we need to start from scratch. And so how much time will that take us, and how can we really genuinely develop partnership when we're distant, I think is another one. Through the work we've had the opportunity to do with new immigrants to Canada, as well as with food insecure populations, I'm cautiously optimistic that we will continue that good work, and we've understood those barriers. But of course, like you said, really there's going to be a lot more, and I love your hint at these are the ones I think might be the challenges. Talk to me in 5 years and I'm sure I will have learned so much.
Yeah, no, it is tough, but amazing that you're going to do your best. It's great. So there are a couple of questions in the chat. So I wanted to start with Faith DeLoss Reyes, who's my our one of our kinesiologists at Women's College Hospital, and she's actually been she helped us develop our diabetes prevention program for new moms. And so her question, I'm just going to read it out. I was wondering if you can provide insight on client feedback collection methods. So in your experience, are there some that are more meaningful? It can be challenging to have clients complete the long surveys, for example, or commit to interviews, focus groups, etc.
Yes, spoken like a true expert research coordinator there. Yes, absolutely. So we do use multi-methods because we're very sensitive to participant burden. So when we first had our kind of get-togethers with our alumni, as we call patients who have participated in the program and wish to continue involvement, the big thing they told us was about long questionnaires and such. So we do it in two-phase processes so that we always divide things into more bite-sized manageable pieces of surveys. And then we do selective ask for interviews, as well as selective ask for focus groups, as well as selective ask for committee membership type of involvement. So essentially, we're not going to ask the same person to do something, to do more than one thing. And then the other thing is making it as convenient as possible. So we have developed our own app that, should they wish to participate in sharing more information with us, they can, but no pressure. As well as I'm sure as you know, using things like RedCap, how can we flow through the process so that questions are hidden when it's not relevant. I know it's not a cure-all, but we do as much as we can to possibly reduce that. The other thing I will say is that every step of the way, I've been more and more critical about the information we collect. So it's really bare bones on the most only critical research questions we're attempting to address. And anything above that is superfluous. We just can't do it because I don't want to burden any participants.
Yeah, and I guess particularly as you're moving towards kind of implementation where you're really sort of de-emphasizing the researchers' roles in the program. Is that correct? So with less researchers, if you're relying on staff, then you don't want to be overburdening the staff either, right? Yeah. Okay, Ghazal, you had a question in the chat, but you also said Jillian read my mind. So is there anything that you wanted to ask or expand on, or are you good?
No, that's great. Thank you very much. My question was answered. Thank you, Dr. Jen.
Okay, great. And then another question is around AI. So do you see a role for AI to expand the program?
I love this question. This is so interesting. If anyone's interested, no. I think absolutely that there is a great purpose and fit for AI. What I believe in right now is we don't have strong enough evidence to suggest that human one-on-one counseling session can be replaced with AI. So I think there's other pieces, like I mentioned already, we tested SMS, and then we assessed through a faster trial design, like how the frequency and the timing of which SMS messages should be sent. And so I think we can automate so much of that stuff. And response to text message, how do we then respond or do we not respond? I think that is beautiful. I think to our current population of individuals who have prediabetes, which for my studies so far have been about 51 years of age, that human connection is irreplaceable currently. And I know things are moving so quickly that in 10 years that may not be the case, but
yeah, no, that's great. I think we've found that too, that the secret sauce is having a person, a human being to talk to. Are there any other questions for Dr. Jung? Just one last question. Okay, and now it escaped me. This is terrible. Okay, never mind, because I don't want to be delaying things. I had a question and then it just left me. Just 1 minute. Oh, yes. Are you looking at peer support as part of your intervention?
no, we are not, but that is a great idea. What has happened organically is some of the people who have gone through the program have requested to become a Small Steps for Big Changes coach. And this is actually permissible because the YMCA really has a fantastic volunteer program. So then we've mentioned, oh, if you want, you can become a volunteer of the Y. They go through their criminal checks. They go through all the training to become a volunteer of the Y, and then they've they are now delivering it. And so this provides a ripe opportunity to look at peer support. I just hadn't thought of that question before. So it's something that perhaps we should talk.
Yeah, no, it's also something that we haven't done, but it's something that's being given to us as feedback, as something clients seem to want. Great. So if there are no other questions, Mary, thank you so much for a fantastic presentation, and really best of luck. This is just amazing work. I mean, you've already done so much, and it's just, now the next phase, I think you're really well set up for success. So congratulations for all of this. And thank you for sharing with us. And thank you everyone for joining today. And please join me in thanking Dr. Jung. And so please be sure to complete today's evaluation for the session. Lydia will add the link in the chat if she hasn't already. Just as a reminder, the talk will be recorded if anybody wants to go back to it, or if you want to share it with people who weren't able to make it today. Please join us for our next Network for Healthy Populations seminar, which is on a different date and time than usual, because we are really pleased to announce that we have a visiting speaker from India, Dr. Viswana Mohan, who will be coming to speak on Friday, February 9th at 10 a.m. And this will be a hybrid presentation, so you can either come in person at the University of Toronto Mississauga campus, or you can join via Zoom, and we will send out that information shortly. The title of his talk will be Precision Diabetes is Now Becoming a Reality in India. And he himself is a professor, very well-known professor from Chennai, India, and he runs large epidemiologic studies of diabetes and its complications, as well as research on novel methods of improving quality of care. And we feel that a lot of his work will be really informative to our network, so please join us. So with that, I'd like to thank everyone once again for joining. Thank you, Mary, so much for a great presentation and taking the time early in the morning from BC to join us. And have a wonderful day, everybody. Bye-bye.